Hello, everyone. We're going to get started. This is Jeanette Gass from IASP. I would like to welcome you to today's webinar on pain and survivors of torture. Today's webinar is the third in a series of webinars related to the 2019 Global Year Against Pain in the Most Vulnerable. You can find out more about the 2019 Global Year by visiting iasp-pain.org/global year. Before I introduce our speakers, I wanted to bring your attention to some information that appears on these slides. There are several ways to participate in the webinar today. After the talks, we will have a Q&A session, and you can type your questions into the Q&A area of your Zoom meeting control panel window. You can submit questions at any time that you would like. We will also be recording this webinar, and it will be available on the IASP website. You can also tweet using hashtag GY2019 and follow at IASPPain on Twitter. I'm thrilled to introduce today's speakers, Amanda C. Williams, Bianca Kuhler, and Lester Jones, here with us today, and I'm looking forward to their presentations on this very important topic. Our first speaker today is Dr. Amanda Williams. She is an academic and clinical psychologist at University College London and at the Pain Management Center at University College London Hospital. She also works for the International Center for Health and Human Rights and has worked for a torture survivor charity in the UK. She has been a clinician and researcher in the pain field for over 30 years and is chair of IASP's Special Interest Group on pain related to torture, organized violence, and war. Please welcome Dr. Williams.
Thank you. Welcome to the webinar. And all three of us are experienced in treating torture survivors, so I hope that we'll have a lot of questions that we can help with at the end of this. I have no disclosures and I'm just outlining my experience. I'm now mainly academic rather than clinical. Torture is defined by pain. There are various definitions. I prefer the World Medical Association one at the bottom right of your screen. But what's important is that it is recognized in legal terms internationally. And that's the UN Convention Against Torture definition at the top. And what matters is that it's not only causes extreme suffering, but that it's inflicted by the state or by state agents. And therefore, although of course pain patients of all sorts can describe their pain as feeling like torture, it can't be used legally in that way. So I'll cover general issues about torture and assessment and psychological issues. Then Bianca Kuhler will talk about treatment in the pain clinic and Lester Jones about physical therapy and rehabilitation. So who is tortured? The common belief is that people who are tortured are either so-called terrorists or are politically active, and they're tortured to provide information. This is a very popular film plot, but it's not reality. Torture doesn't provide reliable information. If you question someone under duress, it induces false memory and false confessions, and those can't be distinguished from the truth. There's no evidence through history that this has ever saved anyone, but it is still used as justification. What torture does is intimidate people from standing up for themselves and their communities, their politics, their sexuality, their language group, their nation. It destroys them, it spreads fear and distrust, so that even if they manage to survive and are released or escape, other people are suspicious about what they might have said and who they might have implicated when they're tortured. So people are tortured for all sorts of activities, but many because they belong to a particular ethnic group or a language group, or in some way their politics don't agree with the ruling party. Most people die under torture. Those that escape, the majority stay in their own country or go to neighbouring countries. Many are living in refugee camps. Only a minority reach high-income countries so that we might see them as refugees who are claiming asylum. And there's no accurate way to estimate how many refugees are torture survivors, but the minimum estimates are around 30%, and it could be many more. I think to have some idea of estimate is important, because then it makes one think when one's seeing refugees regularly in one's clinics, whether one is identifying torture survivors. So how does torture affect people? Survivors suffer all sorts of psychological problems. They're often described very much in terms of post-traumatic stress, which means nightmares and intrusions, hypervigilance, and avoidance of cues. But also depression is very important. People can be quite despairing, have lost their faith in humanity, and feel it's hardly worth trying to establish themselves again. They often feel very ashamed and humiliated about what has been done to them and even what they have been forced to do to other people. And many have chronic pain and other health problems. When I was working in a charity for torture survivors who came looking for help with mental health, we took a large random sample of 1 year's intake, and a minimum of 78%, maximum of 92%, had at least one pain. But pain from torture is often not recognised and not documented, partly because if there are no obvious signs, which is true of many forms of torture deliberately, pain can be discounted. And also because the complaint of pain is often written off as a non-specific symptom of post-traumatic stress. Of course, there's a connection between them, but it's not just a symptom of post-traumatic stress. So we need to recognize who's been tortured, and we have to ask. We can't expect people to disclose it when they have no idea where you stand. If there's time, if you're reading a referral letter before someone comes into your consulting room, then you might have time to find out about the country. And there are many websites which will tell you if torture is prevalent in that country. But you can also say, you know that bad things happen in that country. You can ask why someone left. You can ask directly about attack and imprisonment. If the person hasn't been tortured, it's very, very unlikely to offend them. They'll say no. But if they have been tortured, then it shows that you're concerned, you're prepared to believe them, and you'll listen. And many of the torture survivors who appear in the health service have only been questioned before in relation to their asylum claim by people who are trying to find holes in their stories, trying to find reasons to disbelieve them. So they're used to hostile questioning. You need to show that this is different. The BMJ a couple of years ago had a very good paper by a doctor who is himself a survivor of torture about what clinicians should do. He asks people to explain their role and to be honest about confidentiality. Who can read the notes? Notes in the UK have until recently been shared with the Home Office, and the Home Office is responsible for granting or refusing asylum and deporting people. So that was a very difficult position for patients. You shouldn't be afraid to ask about torture, but explain why you're asking, and don't have everyone in the team individually ask. Read notes or talk to one another. Accept that it's hard to trust people. Those from other cultures may find it very difficult to behave as we're used to patients expecting, to meet the doctor's eyes, the other clinician's eyes, to be able to talk about these things comfortably, and to accept that needs are complex. So in assessment, you need to ask for detail, not just leave it at a superficial level. The torture, of course, may leave no marks, but you need to ask what was done, how, where, and to explore euphemisms. People often don't have words, or they don't know if the words are decent. for parts of the body. So body diagrams can be helpful. And you need to allow for people feeling modest and uncomfortable talking about what was done. I think there are two particular things to think about. One is traumatic brain injury, because it's very common for torture survivors to report loss of consciousness during torture. It means they don't always know what was done to them while they're unconscious, and they may have real difficulties with memory and constructing a coherent narrative. The second is interpretation. People should always be offered an interpreter. Even those with apparently good language of the host country may not have language for emotions. They may have trained as scientists or businessmen and have that vocabulary, but not vocabulary to talk about how they feel. And phone interpretation is often perfectly acceptable and is preferred by some people. So the psychological problems that arise are mostly classed as PTSD, and the problem is that it's a very over-inclusive construct, and it tends not to be cross-culturally completely applicable, so it pathologizes some ways that are normative as ways of coping. But the symptoms, of course, are very real, and they interact with symptoms of chronic pain and problems of chronic pain, so that when someone's pain exacerbates, that may set off intrusions and may make them more sensitive to reminders. And reminders can be all sorts of things, smells, loud noises, people in uniform, all sorts of things can be avoided. But it's important to recognize that it's not all about PTSD. Current distress is also very strongly associated with the current situation, with social isolation, feeling unwelcome in the host country, poor accommodation, lack of opportunity for work or training. And so treatment for PTSD includes education, exposure, challenging beliefs, not entirely unlike pain management, and helping people cope when they're hypervigilant and tense and even panicking. But overall, the treatment benefits are fairly small because torture survivors are often starting from quite severe level of symptoms. I think the UNHCR advice is good overall advice to propagate throughout healthcare. All clinicians can be encouraging self-reliance, providing education, and so on. The meaning of pain can be very complex. When I first went into the field, I assumed it would always represent something unwelcome, the torture and torturer somehow staying in the body of the tortured person. But in fact, it can also symbolize having survived rather than died, which leaves people ambivalent about wanting to get rid of it. It can mean all sorts of things, and that needs exploring. But current psychological and social problems often seriously complicate assessment and treatment. Certainly in the UK, people are on an extremely low income, and they often have to choose between eating or phoning relatives in another country, or taking a bus or train to see their solicitor, or taking a bus or train to get to their healthcare appointment. So pain is often not the priority or what they can afford to address first. There are few studies of treating pain in torture survivors as a specific population. We found only 3 in a systematic review. 1 was physiotherapy, 2 were rehabilitation, and all showed rather low efficacy. Some of the studies of military veterans, I think, offer us helpful ways of combining treatment for pain and PTSD and psychological problems. And of course, one should offer the best available treatment, which for many people will be pain management programs, but so far there isn't a body of evidence, published evidence on efficacy. So where do we go from here? Well, pain management needs to be seen in a human rights context with survivors of torture. Asylum is a human right, so are reparation and rehabilitation, but they haven't really been recognized or defined or enacted by any country yet. We need to think of pain treatment in the broader scope of rehabilitation. And we need to work with our colleagues and students to improve recognition of torture survivors, most of whom we know still go unrecognized. to provide best assessment and treatment, to liaise with torture survivor services, get feedback about what would help, what helps most and what isn't helpful, what could be better, and document the work and share it. There's so little in the literature about actual treatment, and single case methods are very applicable here. So we always need to acknowledge with survivors of torture that torture is wrong, but recovery is possible. We need to offer hope and establish good trusting relationships, make sure interpreters are provided where they're needed, identify people's strengths and resources, because many of these people have shown enormous strength and resourcefulness in surviving torture and getting to wherever you see them as a refugee. And I think we should go beyond the level we usually do in addressing current living problems, because they're going to worsen someone's psychological state and they're going to affect treatment unhelpfully if we don't. Thank you very much.
I'm sorry, everyone. Thank you so much for Dr. Williams for this excellent presentation. Attendees will have the chance to ask questions after the presentations. I would now like to introduce our second presenter, Dr. Bianca Kuhler. Dr. Kuhler is a consultant in pain management at Chelsea and Westminster Hospital in London. She developed several specialized multidisciplinary clinics together with her colleague, Dr. Susan Childs, which find treatment options for patients with fibromyalgia, mental health problems, and those who have suffered torture. This service for patients who are survivors of torture is the first one in the UK. Welcome, Dr. Kuhler.
Of course, it's a big subject, and there is part of it is, of course, acute pain, which we might see after patients have had trauma, but we also see acute pain in our hospitals after surgery, and it is important that even in this setting we understand their previous history, that they have been tortured, because there might be a high risk of post-surgical chronic pain, and also the patients might exhibit a lot of pain when we treat them post-operatively. But I'm not going to talk about this. I'm not going to talk about assessment for legal purposes, which is a very specialized process, and it's going along with the Istanbul Protocol, and this is to claim asylum, and often doctors have to make very clear report, have to write very clear reports. That's very specialized. So I'm talking about chronic pain. This is my day-to-day work I'm doing. And can we go to the next slide? Okay, now, okay. So by the time I see these patients, that is often down the line, because it takes all of our patients, or a lot of our patients, years to come to a pain clinic especially patients who are survivors of torture, as Amanda already was pointing out, that they have all these other problems. They are claiming asylum, which is very much on the forefront of their problem, because if they don't get asylum, they might be sent back to the country where they have been tortured. So by the time we see them, often this has resolved, but not in all cases. Next slide. Okay. So when we get patients referred to our service, we have basically two different types of patients that are in the referral letters to us. And in our service, we do get referrals from general practitioners or family doctors, and or from musculoskeletal services. And some of these are telling us that the patient has been tortured, and the pain is still related to torture, and therefore it's a very clear picture. The pain might have gotten worse over the years, but we can look at this in the pain clinics. But the interesting one is when we get referrals about a new onset of pain, for example, low back pain, which is not an unusual finding. Is 90% of this population at one point in their life will have back pain. But if it happens to some of our patients, and they might appear to have functioned very well up to that date, but usually it's not mentioned that they have been tortured. There might be somewhere that a diagnosis of PTSD, but often we don't know anything about it. And the interesting bit, they are referred often like patients suffering from fibromyalgia, pain behavior exceeds clinical finding, or I've seen somebody write psychological somatization or secondary gain, no torture mentioned. And the interesting bit about fibromyalgia is we all know that the condition diagnosis is made after exclusion of other conditions, but obviously a previous torture experience has not been excluded. So next picture. So looking at our patients, how they previously experienced the medical system or different medical systems. And I just want to add something because Amanda already talked about a lot of the aspects, but I want to add a few more. So next one. So doctors might actually have been involved in torture. Either they were torturing the patients themselves, or they provided treatment for them to go back to be tortured again. So the experience of torture survivors might be a very negative one about doctors. Also, in refugee camps, they are not necessarily safe. They might get some treatment, something, I've seen patients, they had a fracture stabilized, but it was not properly treated. There was still ongoing problems from this point of view, because the treatments, of course, are different standards. But what we often shouldn't forget that sometimes torture happens in these refugee camps. They are not necessarily safe places. And the other one, Amanda already mentioned, the asylum status. And they often have to respond to very detailed questions. And they go so deep, these questions. They sometimes might be even asked, what was the room like? What did you wear? And really, really detailed questions. So that might lead to further re-traumatization. Okay, next one. So another problem is the medications. Patients often come with a bag like this, and they are not consistent. Medications are used from different countries. They are prescribed by different healthcare professionals. In the UK, we have a GP system which does allow a little more logical approach to that and a bit more containing of this mixture, but still patients come with my brother takes this, and my brother and my uncle takes this. And there's also a myth around health that more medications and the more stronger they are, the more helpful it is. And compliance can be difficult. So that if you don't understand as a patient that you should put a buprenorphine patch on, for example, every day, 7 days a week, and put it on only when the pain is bad or medications have side effects, and it's not nice to use them. There's also a big fear of unhealed tissue damage, and that further investigations will fix the damage, will find the damage, and then we fix it. And yeah, next picture. So these patients come to us, they have often been seen by multiple services, and this includes psychotherapy, psychology, orthopedics, neurology, neurosurgeons, and even pain clinics. And interestingly, often when we see them, nobody had asked, have they been tortured, or what happened in your country, any of these questions that Amanda was mentioning. And of course, the more unsuccessful treatments there are and failed treatments, the worse, the more frustration there is, and the bigger is the impact on the quality of life. So it's a very vicious cycle. And the patients often feel that they are not understood because somebody might have mentioned, oh, PTSD, and the pain is related to PTSD. And then they come and say, oh, somebody said in my head. Also, when we want to treat our patients and we want to help them, if we don't know about their previous history, they might go on a big injection list, things done quickly and without explanations, needles used, TENS machine capsaicin patches, and nerve conduction studies with needles EMG. All this is nothing wrong. We should still treat our patients, but they need to understand what's happening, and we need to understand what they have been exposed to. And we don't need a number 103 EMG test if we know the patient has a clear nerve damage and lesion. So we don't need to prove it with every neurologist they see. Okay, and also pain medications mentioned earlier might cause side effects or no benefits. But since there's nothing else to help with the pain, they often use it, and sometimes use it patchingly or sometimes overdose on it without understanding. For example, with medications like cocodamol or diethylmol, using too much paracetamol is a risk. Okay, next. So in this patient group, it's these factors like our biopsychosocial model is, I think, the most pronounced of all patients, because we do have the biological factors, which is, and part of it is expressed in pain, but also other chronic health conditions, because they might have had very bad circumstances where they were in prison and tortured, but also the psychological factors and trauma, PTSD, plus refugee status, housing, family. And so this is very big overlap, and we really need to understand this in these patients. It's even more, I mean, I can't say it's more than anywhere else, but it is very significant. Next one. So what are the medical concerns that we have? Next. So, of course, there can be structural changes from trauma, fractures, nerve damage, damaged joints, or, as I was saying earlier, poor general health, scars, scar pain, and that has nothing to do with PTSD. This is a very clear, defined pain that we can treat in a pain clinic. Fractures, of course, should have been treated earlier, but still we shouldn't overlook anything like that that had happened. And Amanda already mentioned the possible brain damage. There's loss of consciousness, and we don't know how much brain damage there actually was. The other one is a classic neuropathic foot pain that patients have after phalange beating to their feet. And there is a nerve damage in this area. Now, if such a patient now on top of this gets a diabetes or diabetic neuropathy, their pain will increase on the already pre-damaged foot. So this can actually worsen it, and we need to understand even the secondary diagnosis of diabetic neuropathy in such a background in more detail. For example, shoulder pain, brachial plexus damage, weakness after suspension, we see this often. And then there's the patient coming with widespread pain, problem sleeping, sensitivity to noise and smell and this sounds quite familiar, is this is one of our classic complaints. We'll see in our patients having fibromyalgia, so deep widespread sensitized nervous system with a wind of everything, including and which correlates also to their anxiety levels, their problems sleeping, and everything is interconnected. So psychological problems, PTSD, depression, and something that happens in a clinical setting. And if we're not used, I remember my first time it happened, that when asked a patient about previous exposure to torture, and they all of a sudden become very distant, and they seem to be there, and having a patient dissociating as a medical doctor for the first time and having no idea what this means, it is helpful to understand and to understand also a few grounding techniques to help these patients to move on from this situation to the next one. Next picture. So what are the treatments? Basically, it's very simple, is best medical standard of care. That's what we need to treat these patients no matter what. So patients need appropriate investigations, treatments, and consent needs to be clear. The medication should be optimized, also interactions taken into account. Because what might happen in a pain clinic, they come with antidepressants. If we don't really ask them about that, we might suggest another antidepressant. So it can quickly happen, patient comes as prescribed in the end 3 or 4 antidepressants, takes tramadol on top of it, and here is a big risk of, for example, causing a serotonergic syndrome. So we need to take time to give clear instructions and explanations, what to expect from treatments, and to allow space to consider alternatives to medical treatment, because something does not have to happen. They have to really understand, is this a good pathway for them? And also other treatments might be successful as well. It doesn't have to be a medical approach. And always be geared up to patients' physical needs and life experience. Next one. So the reason I found myself in pain clinics, as I mentioned before, with patients feeling psychologically very unwell. And then I wanted one of our psychologists, and I'm working closely with Dr. Stephen Child, our lead clinical psychologist. And then I sent patients for her to see, and they just do not show up. We call it DNA. And then I see them again, send them again, and so on. And that can go on multiple times. And in the end, we decided just to see the patients together, just do it differently. And we have set up this clinic, and it's been very successful for our patient experiences, but also for clinicians to be especially geared to these patients. So what we have is a medication review, usually by a nurse. Just if they're not around, I would see them first with it, but usually a nurse. And this is very nice because they can leave the patient still in this medical setup looking at medication, and then they'll let us know what's going on. We find it very important that the surroundings are quiet. All of our staff knows that we're running that clinic at this time. We, for example, changed constant television with news in the waiting areas to some quiet, relaxing pictures. So we're with a whole team. It's a whole team approach to run this clinic. And what we do find in our patients is that SOTs, so survivors of torture, 53% of those patients were on antipsychotics, and 86%, nearly 90%, on antidepressants. Whereas when we compared it to fibromyalgia group, which we also run multidisciplinary, we found the same number as in the control group, about 53% of antidepressants. And I'm not talking about the 10 milligram amitriptyline here, I mean proper antidepressants for depression treatment. So I see the patient again, like I mentioned before, they explain investigations and treatment, and also seen at the same time. So they need to tell their story only once by a psychologist, and then they can enter our therapy services. And Lester will talk more about this, being a psychologist, physiotherapist, and he's from therapies and rehab, so going in this direction. And or we see the patients either in a group or in a psychologist physiotherapy setup 2-to-1. Okay. Next one. So this we found reduces re-traumatization, rationalizes the medication, could increase adherence, allows medical and psychology assessment at the same time, and reduces DNA. These patients do come to these appointments because their expectation is to see a doctor. And if they see a psychologist at the same time, it is really helpful. And the medical interventions can be planned for complexity. We would let the team know if we suggest an intervention or injection, that the nurse is involved, and so on. So it's a pathway to move patients forward towards accessing a wider life than just only the pain resolution. It's more a multidisciplinary approach. Next one. So just to conclude, next one. Okay, so this type of setup, and I know not everybody has a psychologist, but if we do in any multidisciplinary pain clinic, I think it is useful to see them together in a setup for them. We can ask the right questions, establish trust at this consultation, which gives them much more time or much more flexible. And we also can help them not only get the best care, investigation and treatment, but also help them to understand the nervous system. And we also found that activity-based interventions might be better tolerated than psychological, except that, for example, when we talk about acceptance, in the word acceptance commitment therapy, we still work towards their goals and values, but the word acceptance, I think, needs to have a different connotation in these patients. Okay, so next one. So this is just our big team and all members of the pain team. I want to say thank you. We're all working towards the patient. Next one. And so that's finished. Thank you very much. And this is my email address if there are any questions.
Okay, thank you very much, Dr. Kuhler, for a very interesting and informative presentation. I would now like to introduce Lester Jones. He is an Australian-trained physiotherapist and academic currently working in Health and Social Sciences cluster of the Singapore Institute of Technology, and was the first physiotherapist to graduate with a Master of Science in Medicine with the pain management specialty from the University of Sydney. He is co-author of the Pain and Movement Reasoning Model, has worked at the Victorian Foundation for Survivors of Torture, and is the research officer for the IASP Special Interest Group related to pain for torture, organized violence, and war. Please welcome Lester Jones.
Thanks very much, Jeanette, and thanks to Amanda and Bianca for your great insights and wisdom. I have a few slides that I'll quickly flick through if I can find the right, yes, we go. They're important, but you can look at the detail when you're YouTubing. We won't spend a lot of time on them. But first, here's the people who've helped inform and nurture my approach to survivors of torture. These are my current affiliations. And I have no disclosures apart from the fact that I'm the co-creator of the Pain and Movement Reasoning Model, which I refer to in the presentation. Here's an outline of my talk, and I'll focus on the principles of interaction and then some aspects of the physiotherapy management that I think are important. These principles and objectives come from the Branching Out project, which has been developed by Melanie Block and her team at CoHealth in Melbourne, Australia. The team is interdisciplinary and works in community health settings, and Melanie is a physiotherapist. I believe the principles and objectives are useful to consider by all health professionals, but as is my focus today, by physiotherapists. So the principles are: taking a person-centred approach where the process starts where the person is, and importantly recognises the strengths the person brings despite the horrific experiences she or he might have had. Trust is built through providing physical and emotional safety in a secure environment. So taking a history in a curtained cubicle, for example, is not appropriate. It is important to create interactions that support shared respect, shared meaning, and shared knowledge, and that are predictable and allow the person to have control over their experience. At the system level, there needs to be flexibility. So there's the capacity for collaborative practice with external services, with consent, of course, that supports the person holistically and with continuity. Good communication. We need to listen intently and with compassion, and ensure there's a clear process, including consent and confidentiality, for managing disclosure across the team. And when an interpreter is required, it's important to use an appropriately qualified one, as Amanda suggested. And ideally, the person should be able to select someone who is sensitive to cultural beliefs and to the person's concerns about disclosure in their own community. And that is the choice, I guess, means that it's a choice more than just language. I think it goes without saying that collaboration is essential between client and all those involved in support and development of the person. And finally, according to the UN Convention Against Torture and Other Cruel, Inhuman or Degrading Treatment or Punishment, a person has a right to rehabilitation. I think that another principle could be creative. Maybe that comes under flexible. And I just want to briefly spotlight this work led by Diane Truong, working alongside Melanie. This interactive pain education tool involved images and storytelling to reduce the barriers of language and literacy. Essentially, it's a felt board with pictures representing different aspects of the pain experience, and the person can incorporate these into her or his pain story, or the houses that you can see on the right-hand side, which are the representations of the person's pain story. To bring some of Amanda's works, it's important to avoid the risk of flashbacks or re-experiencing. And this marries nicely with the branching out principles, in particular the emphasis on detailed explanations and informed consent. It's important as a physiotherapist when working with the person's body with manual therapy or teaching exercise to describe step by step what is involved and to check the person is comfortable with the plan. And then that step-by-step description should continue during the process while reminding the person that they are in control and can stop at any stage. While it is our responsibility to provide rehabilitation, there is not a lot of clear guidance for physiotherapy. I believe that those working with survivors of torture should be trauma informed in order to understand the wide aspects of trauma has on health and well-being, which Amanda's alluded to, as well as to optimise outcomes and avoid doing harm. A part of that, and to me something that is at the heart of person-centred care, is to engage with the person's expectations and beliefs about their pain and their values around recovery. And in line with pain management guidance or chronic disease management guidance, we should strive for enabling the person to manage their pain themselves, to give them back the control. So this is the pain and movement reasoning model. The three categories reflect pain mechanisms that we suspect can operate concurrently. On the next slide, we'll see it applied as a way of forming a clinical impression or formulation. But here I wanted to flag 4 aspects of physiotherapy assessment that are important with pain. And not just pain in survivors of torture, I guess. If we start at the bottom right, we should identify any mechanical or chemical triggers for nociception. Is there any injury to or distortion of the tissues? Moving across to the left, we should also determine if there is any issues with structures that are remote to the site of pain. For example, postural changes that are altering load at a distal location, or referred symptoms coming from a spinal structure. And finally, at the apex of the triangle, we should recognise the prior adverse life experiences might lead to what some authors have called a pain vulnerability or a primed or sensitised nervous system. And we also should acknowledge that current stresses and beliefs might increase the alertness or sensitivity of the body's protection system, including the detection of danger. and the triggering of pain. So here I've tried to highlight some things that could be important to the pain experience after torture. Again, we'll start at the bottom right. In the context where I've encountered survivors of torture, namely in a destination country, usually some years after the torture, it is rare for the local tissues to still be injured. But the person might have a new problem, so don't neglect this space. It's also not uncommon, though, to have distortion to tissue as a result of healed but poorly aligned fractures or unreduced dislocations. As well, and invariably, the persistent protective muscle activation around a pain site will itself be a source of pain and tenderness. In the model, these are attributed to the local stimulation category. After torture, people are likely to be poorly or undertreated. As a result, antalgic ways of moving become habitual and can lead to muscle and joint changes due to abnormal loading on tissues. Some torture techniques can lead to peripheral nerve damage, as we've heard from Bianca, that can be associated with poorly localised neuropathic pain. And we've categorised these issues that contribute to the pain but are remote to the site of pain as regional influences. The last category captures things that we feel might modulate the central processing of pain. Of course, the torture experience itself has the potential to prime the body's protection system. A psychological and even a physiological vigilance may result. But the additional hardship in the country of origin and the adversity often associated with the refugee's journey to safety is likely to contribute too. And then the resettlement process, again, also seems to add significant load onto the person, including the concerns one might have for those left behind. As a result, there's a potential for the person to be primed to respond to even low-level physical challenges or injury with significant pain. Negative emotional events are likely to also increase pain reports. And I often describe this state as one of over-applied protection. And I think physiotherapy offers some strategies that might help here. There are four main management strategies I'd like to present. The research base is growing for some of these, and the reinterpretation of how they work, their therapeutic action is apparent in others. The first two are drawn from research looking at training the brain to interpret triggering sensory input differently. Tactile acuity training involves using sensory stimuli to train the brain to improve the awareness of location and of the mode of the stimulus. So that's like sharp versus blunt, for example. It's being used with good effect in phantom limb pain and also with some effect in people with persistent pain. But there's been some dispute as to exactly how it improves pain. Researchers have reported, though, that asymmetry in the cortical representations of a pain-affected body part can be corrected with tactile acuity training, and that correction leads to pain reduction. Graded motor imagery uses a range of inputs to create implicit and explicit motor imagery. An implicit movement strategy involves the unconscious mental rotation of body parts that occurs when someone's making it or involved in a left or right discrimination task. And the explicit motor imagery may begin with a mirror image of the unaffected side of the body appearing as the affected body part, or simply it might just be imagining the movement. Graded motor imagery allows someone who may find the actual movement too confronting to step back and to practice at a level that they are comfortable with before progressing. Manual therapy allows for contact. As you can imagine, the person needs to be well informed and well prepared, but when delivered in a safe context, it can be welcome and can be the first caring touch a person has received. The central processing of manual therapy is apparent in the work of Bialski and colleagues and can be used to initiate an interruption to the over-applied protection I described before. But it is unlikely to last, as the default protection will re-establish itself eventually. And I suspect that this is why people with persistent pain report physiotherapy or massage only helping temporarily. The interventions have interrupted but not changed the default of over-applied protection. Exercise or targeted movement can achieve this, as it can be experienced much more frequently, and I suspect also because it's generated internally. Activities that are valued, are culturally acceptable and enjoyable are probably going to be more effective than gym-style exercises that have a singular focus on strength and endurance, unless the person's a gym junkie, of course. And here's what the latest science is telling us about outcomes of exercise. It can be stress buffering, it can reoxygenate, it promotes movement variability, and has an anti-inflammatory activity. If we expand the focus of exercise to include these additional benefits and not just focus on strength and endurance gains, the range of activities is broadened. And also the resources needed can be quite minimal, which may be important, particularly if the person is under financial stress. I'll briefly give some examples at the end of the presentation from some cases. But I do want to make this important point. It's easy to associate vulnerability to survivors of torture, and it's true there's definitely a fragility that needs care and compassion. However, we also need to acknowledge that there's often a great resilience. These people are survivors of hideous acts, and often survivors of difficult and challenging journeys. Health professionals working with survivors need to have culturally informed skills and sensitivities to successfully assess and manage the vulnerability associated with the ongoing effects of trauma. But at the same time, it's essential to preserve the culture, beliefs and behaviours that support resilience. And so I want to briefly share with you 3 cases where I think I was able to tap into the person's resilience, but that might not be the right phrasing, but to help them rediscover movement and activity. So Sunni was a man who was in despair at the state of his country of origin. He felt he was witnessing the crushing of his people and his culture whenever he received news. He had been a farmer in his community, a provider, and he felt that growing things was more than just producing, it was tied to his spirituality. To tap into his resilience was to start to look at rehabilitation that involved that sort of growth aspect, the growing plants, gardening. But I needed to listen really well to truly appreciate the significance of these activities, that these activities had to him. It was really a life force for him. Jim was struggling with social issues and also progressive visual impairment. He loved sport and I suspect prided himself on his physical abilities. To tap into his resilience, I discovered he used to enjoy juggling. And we introduced initially a one-handed version, which led to tales and laughter of how he used to compete with his brother in juggling competitions. He also shared as part of his journey that he'd spent some time in a school which included a daily meditation routine. He'd forgotten about this, but was reminded how beneficial he found it during difficult times and was willing to reintroduce it. I believe I only became aware of the potential value of juggling and meditation by giving Jim the space to share his stories. I think sometimes it's too easy to close people down and not allow them to show you the way. The third case is perhaps my saddest tale. Mac was in detention with no indication of when he might be released and not even a process to follow. His wife and child were free to live in the community and he was allowed only limited contact with them. I'm not proud that this was happening in my country, Australia. In fact, I remain quite disbelieving and devastated. This still seems to be happening. Mac was gradually losing his sense of self and described feeling emotionally numb. It was awful to see, actually. But there was one joy for him, and it was the opportunity to play cricket with the fellow detainees. Cricket was the way to tap into his resilience in a way that nothing else could. And it was easy for me, once I knew, to integrate the activity goals into his passion. And for a short time, it provided a real life force for him. Unfortunately, he eventually discontinued coming for sessions, and I suspect his mental health deteriorated. But it was incredible to see how such a broken man could be energized with the right trigger. And while things don't always work out, physiotherapists can help survivors find their source of strength through physical activities that the person values. We need to sort of make sure that we do our assessment to determine what those activities can be. As a take-home message, this simple statement from physiotherapist David Kelly is perfect, I think. Survivors are not victims. They are strong and resilient people. It is our task to find ways to support the processes that nourish and enhance that resilience. Here are some online resources that you can watch back when you're searching the IASP YouTube channel. And thank you for listening.
Okay, thank you everyone for our wonderful presenters and their talks today, and thanks to the attendees for attending live. We have a few questions that are coming in through the chat and the Q&A. So a couple of people have asked, what is the implications for treating children that are survivors of torture? Is there anything different in terms of what you would recommend or what you've seen in your practice or anything like that that you could maybe touch on?
It's Amanda here. I'd say the treatment tends to be much more family-based, trying to normalize life and re-establish school and other activities. It's much more difficult when they're child soldiers. There are a lot of interesting projects going on, mainly in low-income countries, trying to rehabilitate child soldiers, but there's very, very little research to tell us what are the better ways to do it. But in terms of children in general, it really needs to be done in the context of family and re-establishing family ties and confidence.
Okay, that's good to know. That's good to know. Another question we have here is whether this information is applicable to interpersonal violence. The question says it feels like much of the information here is applicable to survivors of abuse, major crime, human trafficking, etc. Are there differences to those who are survivors of interpersonal violence?
The definition of torture puts it in a particular context, so of course some of the experiences are shared by survivors of interpersonal violence, but it really is rather different. It confuses things to try to combine the two into the same thing. They're not the same thing.
Okay, so we have a follow-up to the question on children. Is there any data or experience on children who have observed torture and not just those who have experienced it?
Yes, and I think largely the same very family-based approaches are used, but this is not an area I have personal experience in. Certainly, using methods like drawing and play and storytelling can be very important just to begin to understand how the child has processed what has happened before one dives into treatment. So there's a certain amount of treatment that's containment and trying to re-establish a normal life. But in terms of that child and individual trauma, it may require one-to-one work, trying to understand what the child thinks has happened and why he or she believes that happened.
Okay, so we have another question here that asks if there are benefits to physiotherapy in cancer pain patients. Lester, did you want to answer that one maybe?
Oh, look, I think certainly I don't work with cancer patients, but I think that one of the things would be that we would anticipate that a lot of the treatments that we've talked about today will have some value with particularly patients with persistent pain. And I think that increasingly the understanding of the benefits of movement and particularly in the process of recovery growing there. So I think that physiotherapists, I suspect, will have an increasing role in management of all patient groups. But again, I haven't got specific examples from a cancer patient context.
Okay, one of our other listeners would also like to know, how do you come up with a physiotherapy clinical impression in the case of SOT, survivors of torture, I guess. That's the abbreviation. Yeah.
Sorry, could you ask the question again,
Jeanette? Yes, how do you come up with a physiotherapy clinical impression in the case of survivors of torture?
I guess the strategy that I've used is using the pain and movement reasoning model to try and determine, first of all, what are the components that might be contributing to the pain. With that tool, essentially what we encourage is people to sort of try and weigh up what the relative contribution of those areas is. So I guess there's a range of things that I guess form a clinical impression generally, and I guess a lot of it comes down to your experience. But I think that in the first instance, it's important to sort of identify what are the potential contributors, I think.
Okay, well, that's all of our time that we have for today. So thank you everyone for participating, and thank you to our presenters for their wonderful talks. You can find out more information about the 2019 Global Year IASP membership benefits and the special interest group on pain related to torture, organized violence, and war by visiting our website. A recording of this presentation will be available on our Global Year webpage and IASP's YouTube channel shortly. You'll also receive an email with a link to the recording. You can access it directly that way. Thanks everyone for joining us today.
Thanks, Jeanette. Thanks, everyone.
Yes, thank you.